Okay, perfect. So let's begin our second class. So we were talking about the diagnostic process, and we had types of clinical examination, and this was the main types of clinical examination. In this, complete examination was for our core importance. It had a core importance in our subject, and for as a physician, complete we follow the complete examination. Radiologists follow the screening examination. Emergency examination is done in emergency department, and periodic health maintenance care is done on periodically, monthly, on the on time basis. Okay, so diagnostic process had main steps. This were we talking about complete examination type of clinical examination, and which had case history or case presentation or history taking. Then we had clinical examination and diagnostic aids. Aids mean help, which helps in diagnosis, which were radiological exam, CT, MRI, X-ray, PET scan, biopsy, FNAC, biochemical investigation, full blood count, urinalysis, RFT, LFTs, and then your metabolism, like for example, arterial blood supply, arterial blood, and then how to say as that arterial blood gases, right? And there was a failure of the diagnostic process, which was 63% due to patient assessment issues, failure to establish a differential diagnosis, and then 23% on patient factor. They do not comply, they do not follow up, they hide information. That 20% was communication among providers regarding the patient's condition. For example, if a patient is like if he fails to record properly, then the people who are accompanying with the patient, especially in the periodic case, they fail to communicate the problems, which accounts for 20%, and then 70% of insufficient or lack of documentation. Okay, and then 13% is workflow or overload or workload issues by the physician. This again is a diagnostic process wheel. You can later on see. And now we have a patient clinic experience of uncertainty in the diagnostic process. From the patient side and the clinician side, we have steps. Step one is the patient experience health problem and engages with the healthcare system. The patient has a complaint and goes to the healthcare system, to a physician, to a doctor, and then we gather the information. Which uncertainties can happen in every step are written below. So during step one, these uncertainties can happen. The patient does not understand the symptoms or meaning of symptoms, or we ask some questions he does not understand, right? Or on his own, and then he says, okay, this is not a big problem, and we have constipation, okay, it will be okay, or I have diarrhea, it will be okay. After some days, I have toothache, it will go by its own. Previously, I had a toothache, it went by its own. So this is when the person when the patient is not feeling confident to go for a healthcare system, and he thinks he can solve on his own, and until it becomes a serious problem, then when the patient comes to the healthcare system, and then there is information gathering, and then some irrelevant information and some opinions are not understood by the patient, and patient has some other opinions other than doctor. So these are the uncertainty done during the information gathering part. And some uncertainties are done by the clinician. Sufficiency of information is not there, accuracy of information, the patient lies, patient baseline information is not there, and he's not asking about occupation and this. And then step three is integration or interpretation of the information collectively, right? So it can be objective uncertainty or subjective certainty from the physician. And then while working on the diagnosis, so the ability of exclude the proper or provisional diagnosis or definite diagnosis by the healthcare system or by the doctor. Sometimes there is inability to exclude it because they have not envisioned, the doctor has not envisioned himself with the different parts of the regions, or has not related the disease with other disease processes. So that's inability of the doctor. And then step 5 is communication of the diagnosis. So this is how a diagnostic process works and the uncertainties by the patients and the clinicians in different steps of the diagnostic process. So now we go for the steps of case history. I want you to, all of you, to be very attentive during this so that you can revise with me your case history or case presentation steps. Let's begin. As you all know, these are the steps. First, we go for the personal data. Personal data includes name, age, gender, marital status, occupation, and then we have objective and subjective series, which includes chief complaint or the presenting complaint of the patient, where we listen, we look, and we learn about the patient. So when there is chief complaint, we ask, okay, so what's your purpose of visiting today to the clinic or the hospital? And then the patient starts talking, and we quietly, we patiently listen, we patiently look, and we patiently learn about the patient. Yes. Then there is history of presenting illness. When he has done some complaints, we take out some complaint and ask about, for example, he has a tooth pain for these days, and he also had vomiting, he also had diarrhea, and he had other problems, and he sometimes think he's disoriented, and sometimes he's always nauseated, and he has the hypertension, and he has diabetes. So now for these a lot of problems, but you are just maxillofacial physician, so you should only focus on the oral issues. After saying, okay, for hypertension or other disease, are you taking your medication on time? Okay, so maybe the medication is not working, you need to consult them to a cardiologist or an physician from the internal medicine. Right now we are going to focus on the problem related to your intraoral, extraoral, oral issues and oral issues, right? Dental issues. So these, you take out the chief complaints, you think it's important, and then you go for the history of presenting illness. So out of these present chief complaints, you take, okay, now you ask the patient, can you tell me about this? And during this history of presenting illness, you ask the following questions to get more information of the chief complaint. That's why it's the history of the chief complaint. It's the history of the presenting complaint. It's the history of presenting illness. Okay, then we go for the past medical history or surgical history. If there is some, if he has done some he's smoking, if he has comorbidities like obesity, hyperlipidemia, and then if he has done some surgery in the past related to oral surgery or whatever, so you take the history which will be relevant to the upcoming diagnosis, right? For example, you know, he had a surgery of his femur, he had a rod inside, he's a metallic rod inside, right? And then you go send him for MRI of something, and the patient will be in trouble. Then we go for the specific history for the past dental history of the presenting illness, and if he has done some maintenance healthcare, periodic maintenance healthcare, or he goes to the dentist yearly, or annually, or monthly, or however, right? And then he has any treatment in the related to dental or related to the teeth previously. So this is about the past. And then there is family history, social history, personal history, should not be ignored, right? For example, he has a family history of hemophilia, blood disorders, and he's on your chair sitting, and you take his tooth out, and then he's bleeding, right? And then, why is the bleeding not stopping? Oh, I forgot to tell you, I had hemophilia. Oh, then you are in trouble. Okay, so social history, smoking, and then his occupation is related, because a lot of malignant lesions, for example, is related to factory workers and occupation, right? And then sand blowers, and then a lot of things. So social history is important, and then that personal history, drugs. If he use some drugs, some illicit drugs, and then they have association with your teeth, and then also the infection gets spread all over the oral cavity. which includes the personal habits. So this is important. So this was personal data. The important part should not be neglected. This has 6 headings, and then this was objective and subjective part of your history taking or case history. And now we go to an area which totally depends on the doctor's skills. These were the medical examination and systemic examination. Medical examination, because we are talking about the dental health, so it should be oral and includes extraoral, intraoral, which we will see later. And then we have which includes a review or journal review of the system. And these questions should be asked related or specific to the oral, because we are dealing with our physician who is a dentist or an oral medicine physician. So when you're doing review of system in this department, you should ask question or highlight questions specific to teeth or oral cavity or head and neck region. And then we go to it does not depend on skill of that, it depends on the skill of the radiologist. We have investigation and imaging studies. Investigation, there are journal and specific, which we'll see later, specific to the oral cavity, specific to the teeth, and general like blood count and lab work and urinalysis and this and that. Yeah. And imaging studies, we have radial examination, x-ray, CT, MRI, and then we have PET scan, and we have other examinations, ultrasound. Yeah. And advanced imaging techniques, PET, and then we have PET CT, and then we have a lot of other examination now, for example, contrast and non-contrast CTs and MRIs. And then differential diagnosis and treatment plan is the last step of the case history. So now we have overview. Let's go to them one by one. So case history, personal data, we have patient name for record keeping, for administrative purpose like hospitals or clinics, and for better communication. When you name, when you how to say, address, when you address a patient with using his or her name, it will look more professional, and the patient will trust you more that this guy, this doctor is good, he remembers my name, it means he's serious into my disease, and then he'll be coming back to you. And then this is professional attitude by the doctor. And then gender is important because names sometimes are mixed and they cannot define gender. That time you need to know the gender. And also when you know the gender, there are certain gender or sex related disease. For example, hemophilia is commonly in males, and females, there are sex disease more commonly found. So the gender is also important, which is included in the case history, personal data. And then we have age, because certain age groups have certain diseases. And then marital status, because we need to know the status of the psychological stress of some married people. They may predispose or exacerbate certain oral diseases. So that's why we need to know. Disease. Okay. And then, for example, gingivitis and gingival enlargement related to pregnancy. So pregnancy, marital status, she's married, she's pregnant, and if she has reoccurrent gingivitis and gingival enlargement, it can be related to pregnancy. So maybe we don't need to treat it with some medicine, maybe some mild medicine, or not so extensive. And then when pregnancy is over, this condition will be relieved. And then the occupation is important because of some occupation causes abnormal wear of hard dental tissues such as dentin enamel, such as in the case of glass blowers and stone cutters and sandblasters. Those particles, when enter your oral cavity, they can cause some damage and wear and tear damage of the teeth. And then carpenters hold nails in the mouth. We have seen them, right? When they come to your house and then they have some issues, they are making some furniture, right? So they hold the nails in the mouth, and then it's not good for their teeth. And because these permanent teeth are permanent, because they don't come back, so they should be careful of that. Occupation causes oral lesions due to systemic absorption of metallic and non-metallic compounds, such as working with bismuth, lead, and mercury factories, right? They can cause some oral lesions, and mercury is particularly dangerous. Lead can change the color discoloration of teeth, bismuth. And then address of the patient in personal data is important to throw a light on the patient's social and home background, where he lives, where is the socioeconomic condition of the patient, and for patient's recall. And patient living near factories are liable for pulmonary disease. So if the patient lives near a factory, then you can relate, because some patient living near the factories have some relation with the pulmonary disease, bacillus and a lot of those, And then we have chief complaints. The next step of the case history is the chief complaint, denoted by CC. This is the first segment of database recorded from the patient after the personal data. This is the first segment of the database or clinical database, right? And then CC or chief complaint is written in patient's own words. These are the best. Chief complaint is the word of the patient himself or herself. You should just record the words as they have been spoken out of the mouth. Why? Because this is chief complaint. Why? Even if it's non-medical words, even it's layman terms, this should be recorded in that. And because this is the crux of the chief complaint. There may be more than one single complaint, and these complaints should be written in chronological order with the latest finding to be noted first. So this should be written, okay, from 3 days I have diarrhea, from 2 days I have fever, and like this, right? Okay, it should not be ordered with the latest finding to be noted first. This is a confusing statement. Let's just say where it is. It should be with the latest finding to be noted accordingly. Accordingly, yeah, it should be accordingly. Yeah, okay, let me just share it again. Yeah, so it should be accordingly, not first. Okay, so there may be more than one single complaint, chief complaint, and these complaints should be written in chronological order according to the time, with the latest finding to be noted accordingly. And what is that? What does that mean? Accordingly to what? According to time, chronological order. 3 days, from 3 days I have fever. I had just had fever, I have nothing else. From 2 days I also started coughing and something, and today I have bleeding from the mouth. So chronological order: 3 days fever, from 2 days coughing, from 1 day coughing blood. Yeah, so this is chronological orders, right? This is chief complaint. How to write chief complaint? Okay, first you can write randomly, and then you can sort it out on the right side or whatever. How this depends on your skill of taking history taking. So you need to revise and take history and practice history taking with each other. This is good for your exam, and then in the hospital you have to do it. There is no other way. And as data documented, clinician may be thinking of possible diagnosis that conform to subjective findings. When the chief complaints are formed in your mind, you will also, because you have relativity, and then you can relate the complaints to some of the diagnoses, so you can reach to some diagnosis in your minds whenever you're taking this history, this chief complaint. So right, starting from your chief complaint, you will have some idea of where this disease process is going, where this diagnosis process is going, and what are the diseases associated with this. And then we have some symptoms and signs. For example, symptoms of pain, burning, dry mouth, swelling, paresthesia, and loose teeth related to oral. So now we go to the chief complaints related to oral disease. There can be pain, there can be burning sensation, there is paresthesia or numbness, there can be bleeding from gums or teeth, yeah, swelling of gums, or then there can be oral ulceration, aphthous ulcer, there can be sensitivity to cold and heat, thermal sensitivity, right? And then there can be TMJ disorders, temporomandibular joint disorders, because we also go for the head and neck in the when we are taking history of the oral cavity or patient with an oral disease. And then we have functional disorders, then bad breath, also known as halitosis. And then we have aesthetic problems, like, for example, cleft palate or any aesthetic problem. Aesthetic problem means problem related to the beauty or the facial structure. And then we have regular checkups and referred patient. Regular checkup, for example, a patient comes in and says, okay, doctor, I come for my yearly or monthly or annually checkup. He does not have a chief complaint, but this is, so when you write in chief complaint, this is a regular checkup, that's it. And if he has any complaint, we don't have a complaint, CC none, and regular checkup. And then he has, and there will be referred patient. So whenever there's a referred patient, you write in the chief complaint, this is a regular checkup and it's a referred patient from this, and this is a not in the, you don't write in the patient's information or personal data, you write in the CC, because it's an important part, is referred from that guy or from that department. Yeah. And then you go for the sign and symptoms, which is an important part of chief complaint. So after you getting chief complaint, then you go into the history of presenting illness. While you are going to the history of presenting illness or the presenting complaints, you need to know more about the chief complaint or the presenting complaint of the patient. You need to know signs and symptoms. And signs and symptoms are nothing but, signs are objective findings which you find as an examiner. As a doctor, you find some findings. These are objective findings. These are known as signs. And symptoms are the subjective information reported by the patient. Because symptom has P and sign does not have P, and P is the patient. So symptoms are subjective information given or reported by the patient. P is for symptom and P patient. Given by the patient, information given by the patient. The patient says, it's the report of the patient's own sensory experience. I have pain, I have this pain, I have that kind of pain, I have burning sensation, I have bad breath. All of the colleagues say that I have bad breath and I have this history. Okay, so these are the symptoms. These are usually first aspects of the history to be recorded. Symptoms may be described by, okay, okay. Symptoms can be described by the parents or guardians, as in the children case and the pediatric patient and mentally compromised patients. They can be given by the guardian or parents. And then these are some examples of the symptoms. Now we go to the signs, which depends on the doctor or examiner skills. These are the objective findings discovered by the examiner. A change or any changes observed by the examiner or physician, as change in color, shape, form, or size of the tissue. This is the definition of signs. For example, pulse, blood pressure, mass, if there is mass seen, if there is ulcer, erosion of the teeth, or pigmentation of the teeth, you can see. And then these are all the signs taken by the objective findings by the examiner. And then other signs of disease detected by visualization. So what are the tools for the signs? Inspection, auscultation, palpation, and percussion. These are the tools for the sign. These are the tools for the examiner to record some signs, to know about some signs, to find some objective findings. So these four tools: visualization, also known as inspection; listening, also known as auscultation. We are not auscultating the teeth, don't worry. Okay. Smelling and palpation or percussion. These are the tools used for taking the signs of the patient. Okay, so now we go for history of presenting illness. So these are the things asked in the history of presenting illness. Onset of complaint, when the complaint started, how it is started, what is the character, is it on and off, in 0 to 10 scale, how severe it is, what is the course, how it started, when it started, 3 days ago this happened, 2 days ago it was less, and then yesterday it started again, it was again severity. This is the course of complaint. Duration, how much time, every time you get pain, how much time it lasts, or how many duration, what is the duration, and how many times after some time it comes back, or what duration. And then location of the complaint, where is the site, where is the pain located, where is the complaint located. Okay, I have numbness in my thumb, in my fingers. Okay. And distribution, does it goes to anywhere else, does it refers to any place else, and what are the relevant facts in the patient medical history, what are the relevant facts relevant to this chief complaint in the patient medical history. maybe he or she is taking some medication of hypertension, which is causing some other complaints, yeah, or any disease. Okay, so consider any previous treatment and their effectiveness and prior occurrence. If, oh yes doctor, 6 months ago I also had the same problem, but I didn't think it was serious enough. Okay, so now it's serious. Why you came? So it's now it's more than previous, and I'm disturbed. I had to take leave every day. Prior occurrence, exacerbating factors, relieving factors. What are the things which exacerbate? Okay, doctor, whenever I eat, I had pain in my stomach. Okay, ulcer, gastric ulcer. Relieving factors. Whenever I eat, I relieve the whenever I eat, I relieve the pain in my stomach. Okay, we have some peptic ulcer, right? So duodenal ulcer, gastric ulcer. So these are the exacerbating factors and relieving factors. Okay, doctor, I have toothache, but when I take NSAIDs, the pain is gone. Okay. Associated phenomena such as fever, especially bleeding, and bad odor. Bad odor is also known as halitosis. The associated phenomena. These are the questions after the chief complaint is done. These are the questions you need to ask to know more about the presenting illness. That's why this is known as history of presenting illness. Okay, this is another column. Chief complaint, direct words of the patient mouth. You write them as it is in the chronological order, and then you need to ask questions about the chief complaint done in the history of presenting illness. You need to record those findings in the history of presenting illness. Do not disturb the chief complaint. And then how to take pain history, you must know by this time, but let's just divide the type of pain, the severity of pain, the duration of pain, the nature of pain, initiating factors, exacerbating and relieving factors, localization of pain, referral pain or referred pain. So type, we have ache, mild aches, sharp, dull, stabbing, electric shock, tender touch to pain. Which type of pain you have? Severity, is it mild, moderate, or severe? The duration, the time since onset, when it started, how much time it lasts, or how many attacks of pain do you have in like one day? Nature of pain, is it continuous, is it paroxysmal, is done in the start in the night, or is periodic, on or off? And what are the initiation factors? Doctor, whenever I move my teeth, it start pain. Okay, initiation factors. The patient moves the teeth, touches the teeth, and start. Okay, tender. Okay, exacerbating and relieving factor. Which things increase it? Doctor, I drink cold water and it starts. So exacerbation, cold can sensitivity, right? And relief. Doctor, when I stop cold water, it relieves. The pain is relieved after some time. But I really love cold water. It's hot, doctor, outside. Come on. But so if you have to choose between cold water and hot weather, which? Definitely cold water. After some time, pain is eventually gone, doctor. It's okay. So yeah. So factors. Excuse me. Here is factors. Okay. And then localization, where the pain is localized, and is it going to any other place? If it's going to another place, it's referred pain. So this is how to remember this. You remember this by remembering this guy. This guy is known as Socrates, and Socrates is a mnemonic for pain. Why we need to remember? So that we do not forget any question relating to the pain, which is crucial, which could be important in our diagnosis. So that's why we need to find a mnemonic for everyone, and this guy helped us. How? S is for sight, his name Socrates. S for sight, where the pain is. O for onset, how it starts. C for character, what is the character of the pain. On off, paroxysmal, or like radiation, does it radiate to someplace else? Acuity, how acute is the pain, how bad is the pain? And then T is the A is also elevating factors or associated factors. A is also associated factors. What are the factors associated with the pain? Okay, doctor, when I chew more, the pain starts. Yeah. And then time course, any pattern or previous pain, or the previous occurrence, right? And then E is exacerbating or elevating or relieving factors. And then S is the symptoms, but S is also with the severity. For example, we love to ask the patient on the scale of 0 to 10, 0 being no pain or least pain, and 10 being the most pain. What do you think your pain is? And the patient says 8 or 9 and 10, I'm dying, emergency. Yeah. So these, on the basis of these Socrates, this mnemonic, side onset character, radiation acuity, time course exacerbation and symptoms or severity, we classify the pain to reach to a diagnosis. This is how you take pain history. Very important for the final year student who are going to the clinical rotation. So when you want to revise, you can come back to the slide. This is not only related to the oral medicine, it is also giving you an overall view. For example, we have site. What is the question you ask for these? This is Socrates, Socrates mnemonic. And what are the questions you ask for this? So you see, this is very helpful. This is very helpful. Thank you for this diagram. These are the questions you ask for these, to know about these, and these will be the common answers. You can later on revise on your own. And then we have less than a minute remaining. It's like now it's 2:47. I will see you exactly at 3 o'clock, and then we will take it to the end. So thank you for this. Thank you for being here, and we'll see you after the break. How to escape and show. Okay. Can you stop sharing? Okay, can I stop sharing? Okay, so if see you at 3 o'clock.